Hello, my name is Dr. Leonora Bowen and I'm an anaesthetic trainee in London. I'd like to talk to you about our experiences of establishing a surgical enhanced care unit to provide safe post-operative care for elective high-risk surgery during the COVID-19 pandemic at Croydon University Hospital, a district general hospital in South London. Like many hospitals last year, Croydon University Hospital was hit badly by the pandemic, and in response to the NHS E&I guidance, created the Croydon Elective Centre, which is a separate part of the hospital to manage elective care safely and minimise the risk of nosocomial COVID-19 infections. This was highly effective for day case and ward level inpatient care. However, our ICU and HDU were located outside of the Croydon Elective Centre and were understandably too busy with emergency pandemic work to accept elective surgical patients. In order to facilitate higher risk surgery in a COVID-protected setting, we created the Surgical Enhanced Care Unit, and it is this that I would like to speak to you about today. Our Surgical Enhanced Care Unit, otherwise known as SECU, opened in October 2020. It's a 4-bedded unit on the elective post-operative ward within the Croydon Elective Centre and accepts level 1 and 2 patients for a maximum of 48 hours. It provides ring-fenced surgical beds for higher risk surgery cases, for instance post-laparotomy care or ASA 3 and 4 patients, bridging the gap between ward care and HDU. With 1:2 nursing care ratios and bedside monitoring, it can manage arterial lines, central venous catheters, epidurals and higher levels of post-operative monitoring and infusions. Currently, it does not accept ventilated patients or those requiring vasopressor support. Patients remain under the care of the surgical team, but are also reviewed daily by an anaesthetist. I'd like to take this opportunity to signpost you to our poster, which talks more about why and how our SECU was created. Moving on to our results and conclusions, we found that SECU provided an increased capability to manage high-risk patients in comparison to other hospitals in the region. It remained open during the second wave, except for 1 week when all elective inpatient work was ceased for capacity reasons. 54 elective patients have been admitted through SECU, including 35 patients with cancer. Only 2 patients were escalated to HDU for vasopressor requirements, and no nosocomial COVID-19 infections have been found. This demonstrates our ability to provide safe perioperative care for these patients. In conclusion, SECU provides an easily reproducible model for other acute hospitals wanting to perform high-risk surgery during the pandemic. Close working between the pre-assessment anaesthetic consultants and surgeons is key for patient selection. Flexibility to work with existing processes and staff was important in developing the unit. It's designed as a permanent feature which we hope will endure beyond the pandemic, and as such it's subject to ongoing quality improvement. Thank you for your time.